Okay, we are recording now. Again, I apologize for any technical hiccups. I had to reformat my computer yesterday. Unfortunately, apparently there was something going on and just would not boot, and that was unfortunate, but we got to fix now. Alright, everyone, 3 more. Dr. Mario is a very prolific pharmacist. I don't know if you knew that based on his game. Alright. Aw, poor SeaWorld. Okay, so any questions before we get kicked off here? Anything at all? Okay, so again, this is Pharmacodynamics we're reviewing for here, so hopefully you all remember that. Okay, let's get started. Hopefully you guys can read it. Okay. Which of the following has an inverse effect on aqueous diffusion across a biological membrane? We decided we're going to name our daughter Lipophilicity. Sounds cute. Little lipo, you know. Just kidding. We're not going to do that. There's 65 people. Who's logged in twice? Or do we have like a stowaway somewhere? Someone's getting free education here. It's inappropriate. Okay, so why is it thickness of the membrane?
Because the thicker the membrane, the harder it is to diffuse.
It's on the PowerPoint. That's an answer, perhaps not the best answer. Yeah, so you're right. So the thicker the membrane, the farther the molecules have to diffuse across, the more difficult that becomes, right? So if you guys remember that example I mentioned of an infant usually has kind of that underdeveloped stratum corneum. They tend to have much better flux of drugs across the skin because of the fact that they have such a thin membrane to cross, as opposed to, say, like an adult patient who has usually a much more kind of developed skin. So that can have a direct effect on how much drug actually gets absorbed. So we mentioned, like, seeing hypothyroidism secondary to iodine absorption if you use like betadine for cleansing, things like that. So that's the reason why we can't use a lot of topical products on those very young children. Okay, surface area, if that gets bigger, your flux should go up, right? So that's why we like things like diffusion across the small intestine, because we saw there's those microvilli and that brush border helps with better absorption of things. The difference in concentration was. Yeah, more on the outside, the more flux you're going to have diffusing across its along its concentration gradient. And then the lipophilicity tends to increase absorption as well, right? So the easier it is able to cross those biologic membranes due to lipophilicity, the easier time it's going to have getting absorbed. Okay. All right. Next up. Yes, I'll explain that in 1 second. But the competition is on. Okay, drug is removed from the market after noting increases in mortality. What phase trial is this? It's removed from the market because it's seen to kill people. All right, it's a phase 4 trial. All right, who here has ever taken a drug? You've all been participants in a phase 4 trial. Did you know that? You should know that based on the lecture. Okay, what's a phase 1 trial?
That one's for the dose.
That's helping with dose. Who are you doing the study in? Volunteers. Yeah, hopefully it's always volunteers. You don't want to force anyone into these trials, right? Do they have the disease state? They do not. Yeah, they are healthy individuals. What type of number of people are we looking at? Yeah, like tens of people, dozens of people. Not usually a large amount of people there. What about phase 2? Who's in that trial? Disease-carrying individuals. Yeah, so now you're still looking for things like dose and looking for safety profiles, but now you're looking for effectiveness as well. Good. And how many people are in that trial? Maybe 100, maybe 200, somewhere around those kind of ranges. And then phase 3 trials is what? Still safety, still efficacy, so you're always looking for those. Because again, what type of individuals are in that trial? Still disease-having people, right? They have the disease state in question. And then usually like in the thousands range, right? So this is the largest trials before a drug actually gets to the market. And at that point, it's all kind of post-marketing surveillance. And so everyone's in that kind of phase 4 trial. Yes, ma'am.
Where is like, you know how we see when somebody taking the drug, somebody taking the placebo type of thing? Where is that?
That's usually occurring within phase 1 through 3, right? And certainly you can do experiments after the fact as well. So like once a drug is on the market, you may see trials where, you know, we're going to look at this one ACE inhibitor versus placebo and see which one has a better effect. Or you can do comparisons between 2 different drugs, you know, different classes or different ones within the same class, you know, lots of different things you can do there. Yeah. Yeah, not usually a specific phase. I mean, if you're just doing like pharmacokinetic profiling, like you might do like in phase 1, that's going to be more just looking at the actual, giving the drug to a person and measuring like serum levels and seeing kind of where it goes. But usually like in phase 2, phase 3 especially, that's where you see placebo compared trials. Now, you can't always do that. Like there's some circumstances where you have like orphan drugs. Have I mentioned orphan drugs before? What do you think an orphan drug is? It lost its drug parents. Now it's drug Batman. No, so orphan drugs are things for disease states that have a very, very low incidence within the population. So think about certain like genetic conditions that are very rare. Think about things that like coral snake bites. I mentioned, you know, we get the most in here in Florida, but that's maybe only 50 a year, right? That's not a huge amount of people. So sometimes because the population of people who come down with that disease state is not very common. You have what you call orphan drugs, and they get kind of special processing because you can't do a trial in the thousands of coral snake patients because it's just not super common that it occurs, right? Or some of these genetic deficiencies. So that's kind of outside the realm of what we were talking about. But you may see that if you ever hear orphan drugs, that's what it's referring to, or an orphan indication, something that's very, very uncommon. Back to that lipophilicity, the more lipophilic a molecule is, the more easily it's able to cross those biologic membranes. So highly lipophilic medication is able to cross the skin to get into the systemic circulation. A good example of that from the tox perspective is, have I mentioned organophosphates before? They're a type of kind of older school insecticide. They are very easily able to cross the skin because they're so lipophilic. So they have very good flux, and so even if you have skin contact with the product, you can still get very severe systemic effects from that because it can cross so easily. Another good example is nicotine. Right, nicotine usually found in things like tobacco, and so there are cases where you'd have patients who were migrant workers who were working in these tobacco fields without any kind of like skin protection. They would actually have very significant absorption of that and then developing all kinds of kind of neuromuscular issues like paresthesias and weakness and all kinds of issues that develop from having nicotine exposure, even though they weren't ingesting it. It was all through the skin due to the lipophilicity of the nicotine. You're talking about aqueous diffusion, but it kind of goes hand in hand with, how does it get across that barrier, right? And so, again, every molecule is going to have some degree of hydro and lipophilicity. It's just a matter of how much is it going to kind of skew in one way versus the other. So, in a lot of cases, like for these molecules, they have to be water soluble, right? They have to actually go into solution, but then they have to be lipophilic enough to be able to cross those barriers, or unless they have a transporter or some other thing that can help them to kind of cross, right? All right. Papa Squad. Very naughty name. Should get that up. All right, which song is not required but recommended on a prescription for safe use? So not required by law. You guys should always do this on all of your prescriptions. Okay, so provider signature, is that recommended, required? Required, right? Does that always have to be handwritten? No, you can have electronic signatures, you can have stamps. The only issue with that is when you're dealing with controlled substances, they do, especially for C2s, especially, you need to have a handwritten signature on that, right? Again, C2s have to come on that, tamper evident looking paper, so you can't copy it and, go around to all the different pharmacies. Strength of the medication, recommended or required? Required. You have to have the strength of it on the prescription. How about medication brand name? Not required. And usually you don't necessarily need it for safe use, because usually if you say metformin, or you say metformin extended release, we'll know specifically what you're talking about in those kind of cases, or whatever. So oftentimes brand name are not included on many prescriptions in those cases. How about PRN indications though? So just saying hydrocodone, acetaminophen, take Q6 hours, PRN. Well, what am I taking a PRN for? Am I doing it for cough? Am I doing it for pain? You know, should I be using it after I use another medication? So one of the things we do a lot over at Nemours, and you guys heard of the Joint Commission?
Yes.
Right, so the Joint Commission, what do they do for us? They make a lot of rules, but they accreditate all the hospitals, right? So they go through and say, like, okay, you have to meet these standards, you have to do these certain practices, and if you don't, then you basically don't get funding from things like Medicaid, Medicare, and whatnot. And it has a big issue to do, and so if you lose accreditation, it's a huge deal, right? So one of the big things they look at is medication safety. And so one of the things they don't want nurses to do is have that independent prescribing, where if you have multiple PRN orders for the same indication, so say, you know, you have Tylenol on the profile, you have ibuprofen, you have morphine, they all say PRN pain. Well, how's the nurse supposed to decide which one they're going to use, right? You need to have more specific indications for that. So for instance, what we'll do is we'll say, you know, Tylenol for pain scale 1 through 3. Ibuprofen 4 through 6, morphine 7 through 10, right? And that way the nurse has very specific instructions which one you should use. Or we'll say, you know, give multiple things for fever, right? Tylenol, give it for PRN fever. Ibuprofen, PRN fever if Tylenol ineffective. So again, you know, we add specific things on there to make sure that we don't have therapeutic duplications and the nurse isn't independently having to decide what to give, right? Okay. All right, moving on. Metoprolol or Toprol is considered a beta blocker. How would you classify this drug? An agonist, competitive antagonist, an inverse agonist, indirect agonist. Lost our 64th. Competitive antagonist. What does that mean, competitive antagonist? So it sits on the receptor, right? Does it activate it?
No.
Does it do the opposite effect? It just sits there. It doesn't do anything, right? It has no intrinsic activity at the receptor. It just sits on it, right? So it has affinity, but it doesn't have any actual activity, right? So if it were to bind to the receptor and have the opposite effect, that would be considered what? Yeah, that inverse agonist. It's very uncommon that you have inverse agonists. They're very uncommon clinically speaking, but we certainly have tons of competitive antagonists. So like naloxone, which is an opioid receptor blocker, that would also be considered a competitive antagonist because it sits there and prevents opioids from coming in and interacting with those receptors, right? An agonist would do what at the receptor? It would activate it, right? So what would be like an agonist at these beta receptors? Epinephrine, yeah, that's going to be one of the primary ones we look at, right? So epinephrine is being blocked, its actions are blocked by the competitive antagonist, right? And remember, in these cases, it's all a numbers game. So if I were to have enough epinephrine around, I could potentially, theoretically, kick that beta blocker off of the receptor and allow for that normal kind of activation to occur again, okay? But again, it just depends on kind of what the numbers are going to be there. And then indirect agonists we didn't really talk about so much, but these are things that will kind of bind at different sites than specifically just the receptor site and allow the receptor usually to work better. So in cases, you guys remember when I talked about like benzodiazepines like Valium or Xanax, that's an example of kind of an indirect agonist where it actually binds to another site on this GABA channels. We'll talk a lot about GABA and physio coming up in the next section, but basically it allows for GABA to work better, right? It helps to enhance the effects of GABA to open up some of these channels. Okay. All right. Slagnator back on top. Where's Dr. Toboggan? He disappeared. What is that? Which change could decrease the volume of distribution for a hydrophilic drug? Oh, there's 2 correct answers. Oh wait, did I do that wrong? Yes, yeah, right. Okay, I did that. I did it. Those are the correct answers. I was like, wait a second, what? No, those are right. Okay, so decreased volume distribution for a hydrophilic medication. So why would increased plasma protein binding be correct? Keeps it all in the plasma, right? So you have more proteins around to bind to that drug, keeps it in the plasma. It's not going to be able to distribute out to the tissues, right? So that's pretty straightforward as far as how it can affect that. How about dehydration? Yeah, so the drug likes water, right? So if you had, if you're decreasing the amount of like interstitial fluid you have for the drug to partition out to, more of it's going to be contained within that plasma there. So that would actually decrease the volume of distribution as well, right? How about edema? What would that do to the VD? It would increase it, right? Because you'd have more fluid for the tissue or for the drugs to go out to, right? So if you think about patients who have like ascites, or if they have like pulmonary edema, or just any kind of like massive edema, like you can see the drugs have an increased volume distribution in response to that. And then increased tissue protein binding, what would that do? It would increase it, right? Because obviously that's the wrong answer, so it's the opposite. But also because if you have proteins that are binding it within the tissues, again, less drug is going to be found within the plasma, so again, you're going to have a higher apparent volume of distribution, okay? You guys remember the equation you can use to figure out volume of distribution? It's just three variables, right? So remember, C0 equals dose over VD, right? So you can figure out what VD is by switching that around and say, okay, VD equals dose over C0, right? That initial concentration. So one of the questions that I've had come up previously is like, what effect does dose have on volume distribution? So you would think based on that it makes it go up, right? Okay. So increased dose based on that is based on that equation, you think volume distribution goes up. But what does dose do to the concentration? It also increases it as well, right? So even though you're increasing the dose of the drug that you're giving, you're also increasing that C0 and the concentration. So because those are both going up proportionally, your VD stays exactly the same, right? So VD is going to be more intrinsic to the drug. It's going to be more intrinsic to the other kind of physiologic effects that are going on, like protein binding, based on fluid status, based on all these things. But dose really has no effect on VD. That's going to remain constant because you're going to see a proportional increase or decrease in the concentration. Okay, so it's an important kind of point to clarify there. Okay. All right. So a 70-kilogram male takes 400 milligrams of a drug with a volume of distribution of 2.4 liters per kilo. What is the initial concentration? Oh, good thing we just talked about that equation. I'll do it with you guys. Is that a high or low volume distribution? It's high, yeah. Remember, C0 equals dose over VD. So no, but the math is going to be such that no, nothing like that. So I'm not going to do like decimals or anything like that. It'll be very straightforward for the test. Because I asked about calculators, and they're like, well, we don't do it for any other tests, and so I'd have to have you guys actually go out and buy a calculator, and that sounded kind of rude. So I was like, I'll just make the math easier, I guess. Right? Yeah. People probably feel more comfortable with calculators. 2.4 milligrams per liter. Keep in mind that would also be mics per ml. That would be the same relationship there, right? So if you ever see something listed as like mics per ml, that just equals milligrams per liter. But how do you get the answer? So I can't really draw on there, but let me do a sticky note. Let's do sticky notes. This will work. Hopefully you guys can see this. Okay, this will show up on the recording though. Okay, so what's our first step? 70 times 2.4, right? So VD equals that 70 kilograms times 2.4 liters per kilogram. What does that equal? 168. Okay, so we know that it's 168 liters is the volume distribution for this patient, right? And again, that's based on the actual weight of the patient that we're dealing with. So that's why we multiply 70 times that 2.4 liters per kilogram, right? So that's, again, this would be a high volume distribution. It would be a high amount of drugs being partitioned throughout the tissues there, okay? So what's our next step? So C0 equals 400 divided milligrams divided by 168 liters. And that gives us, see how the relationship goes milligrams per liter now? So that's how we get that, which equals 2.4 milligrams per liter. Got it? Pretty straightforward. Just practice a few times. You know, you can make up questions. That'll show up on the video too. So I don't know if you need to. You can if you want, but I'm just saying it'll be on there. Right. So you can you know, make up your own practice equations. You can try this out. You can just keep that relationship in mind. C0 equals dose over VD. Okay. And if you're dealing with, if you have the weight of the patient and the VD is being listed as certain liters per kilogram, you have to multiply that out first. Okay. Make sure you get the right answer. All right. Mr. Mackey coming up. Okay, 4-year-old 17 kilogram patient with dehydration presents to the ER. What is his maintenance rate of fluids? Sorry, I was dealing with small character count. So we're going to give him fluids. What would his maintenance rate be? Remember that rule? Interesting. It's the 911 rule. He's in the ER. Just kidding. Oh boy, that's a pretty good split there. All right, what's the rule? 4-2-1 rule, right? So 4-2-1. This is a good number to, or a good rule to remember for the rest of your clinical days if you ever deal with pediatric patients. So, what does the 4-2-1 rule mean?
4 milliliters for the first 10. Wait, 4 liters per kilogram per hour.
Yep.
For the first 10.
Perfect. Yep. So for you're doing 4 mLs per kilo per hour for the first 10 kilos of the patient's weight. Okay. And then for the next 10 kilos, 2 mLs per kilo per hour. And then for every other subsequent kilogram, 1, right? So if we look at this, so let's get rid of this. All right, so we have a 17 kilo patient, right? So we're going to say it's for the first 10. Oops, I can't type. Still can't type. First 10 kilograms. What's his fluid rate going to be? Yeah, so 40 mLs per hour, based on the 4-2-1 rule. And then for the second 10 kilograms, be 7 times 2, right? So it's going to be 14 mLs per hour, which equals 54 mLs per hour. And it's an easy thing you can practice with. You can do it. And again, we do this every single day when we're dealing with pediatric patients. docs write for the fluid orders. We go through, we verify them, we make sure that everything kind of makes sense based on what's going on with the patient, right? Now, certainly this isn't the only like absolutely correct answer. This is just the right answer based on that 4-2-1 rule. If you had a patient who was very dehydrated and they want to kind of tank them up a little bit, you could certainly go above that. So if you ever hear like 1.5 times maintenance or 2 times maintenance, that's basically what the number they're using as their baseline for maintenance fluids, right? Okay. All right. Up next. Which of these drugs would be safest? All right. Dang. What is the critical feature there? Grams versus milli. I see you guys could have made a dosing error based on that. Uh-oh. Oh, a 1,000-fold error. That's not good. Okay, so again, what are we kind of evaluating here? Therapeutic index, which is, how do we figure out the therapeutic index? Yep, it's that ratio between the toxic dose 50, or maybe the lethal dose 50 if you're looking at that, over the ED 50. Is that an effective dose in about 50% of your patients you're dealing with? Okay, so looking at this case, what would be the therapeutic index for the red answer? Just be 10, right? So 50 divided by 5 is just 10. So 10-fold difference, that's pretty good. You know, if you had to have a 10-fold overdose before you'd hit that point where you're getting to the TD50, right? How about for the yellow answer? Just 5-fold. So that would be more safe or less safe? Less safe, right? Because those curves are starting to get closer together, right? There's a smaller ratio there between the two. And then the green answer, about 100-fold. So again, very, very safe. But in this case, in the blue answer, 1,000-fold difference, right? So you could take a truckload of this stuff before you'd ever really get close to the TD50, right? And so that would be considered very, very safe because, again, you'd be hitting that point in the plateau where you'd be able to get most people having efficacy before you'd even get close to having the toxic curve show up, right? All right. Again, I'm a stickler on units, so because they can be so very important, so be aware of that. Be cautious when looking at that stuff. Okay, what type of elimination is pictured here? Don't worry about this math up here, it's not really germane to our discussion. Grams will get you.
Race against time, not time to see MD.
Listen, you guys are gonna be medical professionals. Like, you got to make time for accuracy. These are people's lives. It's not a game. Okay. So what is first order kinetics? Looking at the image. So what is first order kinetics? What does that mean? So that's half-life, right? So it's kind of describing, but what's constant in this case? What's being eliminated? Yeah, there's a certain percentage of drug being eliminated per unit of time, right? So the more drug I have on board, the more or less it's being metabolized. More, right? So the higher the concentration, the higher the amount of drug being metabolized per unit of time, per hour, or whatever. So you notice this here. Notice how the drops in hours is going to get smaller and smaller and smaller as the concentration decreases, right? So at this point, have I saturated any like liver enzymes or any kind of metabolic pathways? No, so you really haven't saturated anything. That's why I can keep increasing the concentration and the rate of metabolism keeps going up, right? But basically the percentage is going to stay the same no matter what. Versus if I were looking at, say, zero order kinetics, how would this line look? Yeah, it would just be a very straight line, right? Because again, in that case, zero order kinetics, you're metabolizing the same amount of drug per unit of time versus concentration. So, like with alcohol, it doesn't matter how much alcohol I have on board, how many shots I've done. I'm still going to metabolize alcohol at the same rate regardless, right? So, you don't see any kind of increase in the rate of metabolism because I've saturated all those enzymes essentially. Okay, fantastic. Do you guys know what this value is right here? I'm gonna take a guess. Dealing with first order kinetics. You guys remember that elimination constant? That KE? Yes, we use that value to help us determine basically what that percentage of drug is being eliminated per unit of time. So we do these kind of calculations very frequently when we're doing like when we're doing kinetics on like we're doing therapeutic drug monitoring essentially for aminoglycosides. We do this a lot for like our CF patients or other patients who are on aminoglycosides. We'll be able to use our levels, and once we figure out this elimination constant for the patient, then we can kind of determine like, okay, well, what's their peak level going to be? What's their trough level going to be based on time? And so it can be very useful for us. But again, this will probably be outside of our scope, at least for this test. Okay. Inhibition of CYP3A4 by grapefruit juice would cause which of the following outcomes? The simvastatin or Zocor is a HMG-CoAce reductase inhibitor, which is otherwise known as a statin. Works on hyperlipidemia. What do you think? You know what rhabdomyolysis is? What is that? Muscle, yeah, major muscle breakdown. That tea-colored urine. I hate seeing like post online or someone's like, "This is what my urine looks like. Should I go to the doctor? I don't have any insurance." And they're like, "Yes, you need to go right now, otherwise you might die." And they're like, "Ah, we'll just wait it out. Drink some fluids." Nope, you're gonna die. Good job. Oh wow. Oh boy. Real good split there. Okay. So why is it the right answer? Yeah. So CYP3A4, based on kind of the context clues here, we know CYP3A4 is going to metabolize simvastatin, right? So if I inhibit that enzyme, what should my drug levels of simvastatin do? Should increase, right? So they should go up, which could lead us to risk for toxicity. So hepatotoxicity, you can see rhabdo develop here due to that interaction. Versus if I were to have, say, like a CYP3A4 inducer, that would lead to what? You have lowered levels, right? Because you have more enzymes that's there to metabolize the drug. You'd have shorter half-life. You would have the drug go down to lower levels, and then you would see failure of therapy, right? So you may see hyperlipidemia secondary to that, right? So your blood lipids would go up. Okay, does that make sense? So again, it's important to know, like, if you have an inhibitor on board, what is that going to do to drug levels versus if you have an inducer? Okay. Okay. Moving on. The hotness or spiciness of a pepper is rated by what scale? This is for no points. This is just fun trivia. Yeah, anyone watching Food Network probably has heard of this. Maybe some Alton Brown or something have informed you of this. Yeah, so Scoville's. Scoville's the scale. It's actually a pharmacist who came up, whoever so-and-so Scoville came up with this. But yeah, so if you ever see like the ghost pepper, it's like 9 billion Scovilles or whatever it happens to be. So that's usually the rating how spicy it is. What's a Child-Pugh score? You ever heard of that? That's actually measuring liver dysfunction. So if someone has different grades of liver dysfunction based on their Child-Pugh score. What's a Marquardt? It's dean of the PA school, right? So you ever see Bill Marquardt came to your? Yeah, see. Okay, Pemberton's I just made up. That was just nothing. Okay. Huh? It's a farm? Pemberton. Oh, there you go. Okay. P-H-A-R-M or F-A-R-M? Yeah. Okay. Continuing on. For cocaine, which of the following routes of administration has the fastest onset of action? So using our knowledge of routes of administration. What do we think? What is insufflation? You take your dollar bill and do a line. Yeah, so we snorting cocaine would be insufflation. Hopefully no one has any kind of personal experience to answer this question for them.
Oh, sweet.
Interesting. That's a good question. We're going to answer that in just a moment. So, looking at where these sites are being absorbed from. So, insufflation, where's the absorption happening? Yeah, so it's happening in the nasal mucosa there, right? So you have some absorption there. Ingested, obviously, from GI tract, right? The inhaled form from the lungs, right? And then just injecting it goes straight to the venous system, right? So which one of these routes has the shortest route from the site where it gets absorbed to the brain, where cocaine works? Well, based on the answer, you'd think probably the lungs, right? Think about when you have drugs being absorbed through the nasal mucosa, it's already in the venous system, right? So it's going to have to go through the liver at some point, get drop back into the heart, then it gets circulated through the lungs, then eventually to the left side of the heart, then eventually to the brain, right? So it takes time, right? So certainly you can see effects pretty quickly, but it's not the fastest onset, right? Versus ingesting it is going to be probably the slowest, right? Because you have to wait for it to dissolve and then get absorbed. Injection, where does that go into? Into the vein, right? So then I have to go to the vena cava, to the right side of the heart, up to the lungs, and back to the left side of the heart, then to the brain. Still takes time. It's pretty quick, but not the fastest. However, with the very vascularized lungs, you're going to have very good absorption through there, and then you have go deliver right back to the left side of the heart, then to the brain. So that's actually the fastest.
Are you worried about bioavailability?
Only for the ingested form. Right, so that's actually very interesting as well. So one of the things you see with cocaine is, what do you think it does to, so increases release of things like norepi and epi in the CNS. What do you think it does to blood vessels? Yeah, it should constrict, right? So as we see hypertension from that, we see tachycardia, it should constrict the blood vessels. What do you think it does to the nasal mucosa when it gets snorted? Should also vasoconstrict, right? That's why if you have someone who's does cocaine pretty chronically and they stop taking it, they usually have sniffles, right? Because they have all of a sudden this rebound vasodilation. They get a lot of edema that happens there. But actually, what's nice about snorting cocaine is it's kind of a self-limiting thing. Well, the nice thing about dealing with patients who snort cocaine is that they have a self-limiting effect, because as they continue to use more and more, they get more and more vasoconstriction, so they actually end up having limiting the amount of dose that they can absorb, right? So it's kind of a nice thing they do for themselves to prevent them from getting super, super toxic. On the flip side of that, by having kind of chronic constriction of that nasal mucosa, what do you think it does to tissue oxygen supply? It's going to decrease chronically, so you can actually see nasal septum perforation, actually a hole that develops there due to necrotic tissue forming due to decreased oxygen delivery. So that's one of the things you can see with insufflation. But inhaled is really, really the bad form. And so normally you can't really smoke cocaine. You have to freebase it into the crack form most often. And so that is what usually gets inhaled. And also one of the things you'll see with cocaine is that the faster the faster you can get to a peak level, the more dopamine gets released, the more that reward pathway gets initiated, the more addictive the substance is. So that's why crack cocaine is so addictive, because it's such a rapid onset and then it kind of goes away very quickly. So anyway, does that make sense from the kinetic standpoint? So again, having a good understanding of kinetics helps us to understand how these drugs can be affecting people. All right. All right, P450 making a comeback. Thank goodness. Which of the following categories has the least amount of abuse potential? All right, Schedule 4 substance. So, good. So what about Schedule 1 substance? What kind of delineates or differentiates the Schedule 1 from Schedule 2?
No real use for it.
The medical use. Yeah, that's the only difference there is that with Schedule 2 substances, there's an acceptable medical use for it. But Schedule 2, Schedule 1 have the highest abuse potential that have at least been listed by law, right? Now, does that actually work out in true Like if you were to look at something like marijuana, which is still federally a Schedule 1 substance, versus like cocaine, which is technically a Schedule 2, I'd probably say cocaine's a little more addictive than marijuana, right? But that is at least the legal classification as far as we know it. But as you get into lower and lower schedules, right? So Schedule 3, 4, and 5, you get less and less abuse potential. And so, it leads to things like, a lot of it comes like from the clinical trials that they did to say, well, how likely are people to abuse it? Sometimes it has to do with kind of post-marketing data, which is why things like tramadol, which is kind of like a partial opiate agonist, was unscheduled for a long time, but then they saw abuse was going up with it, right? Because when it's unscheduled, it means you can get prescriptions with really no hindrance in a lot of cases, and so they moved that up to a Schedule 4 substance, right?
Sorry, question. So
Yeah.
Is that Schedule 1 drug like marijuana medical or approved for medical use, does that then change to a Schedule 2 drug in that state? Or no, because these are more federal laws?
I haven't seen the actual laws itself. So like in Florida here, we have like a Schedule 1 drug list, right? And so that's why like when you guys are familiar with like bath salts or like K2 and spices, like synthetic cannabinoids, when a lot of those were coming out, the state responded to that by adding all of those substances to the Schedule 1 list to make it, basically a crime to have any possession of them. It's a felony. But I'm not actually sure what a lot of those other states are doing. I think for us, I don't know that we amended it to have, I don't actually even know if marijuana is listed in the Schedule 1 list for Florida, because again, a lot of times if it doesn't say anything in the state laws, what do you fall back to? The federal laws. You always go back to kind of what's more restrictive. Marijuana is just kind of an interesting one because a lot of basically the government's like, hey, we're not going to, pursue this, and so the states are kind of left to kind of do what they want with it. Do you guys see who recently decriminalized marijuana? What state? New Hampshire. Yeah, so 60 days from now, you can go to New Hampshire and do what you like with marijuana. So, anywho, all right, moving on. What is the standard expiration dating on a prescription for a non-controlled substance? One person's really not sure. Or they're not in the room. 1 year is the standard expiration date for a prescription, right? So from the time you write it, it doesn't matter how many refills you put on there. After a year, prescription's no good, right? It automatically falls off. How about for, say, like a Schedule 3 through 5 substance? Remember what we said for that? Only good for 6 months, right? So you can write up for like, say, the first month supply and then 5 refills. That's fine. But if you wrote for like 7 refills, that would just get expired after that 6-month period. And then, yeah, so it's basically it for C2s. Remember, you can't write for any refills on those. So it's really just good for the kind of the first fill when it gets presented for filling there. And again, on the prescription bottle that you get from the pharmacy, what's the expiration date they put on there? They still put a year on there. So even though the drug itself might have had a later expiration date, which is why a lot of people think, as soon as that year is done, I think the drug's no good anymore, which is not really the case. So I can go on a long tangent about expiration dates, but most of the time they're bogus in a lot of cases. So non-controlled substances, 1 year is going to be the standard expiration date. So you can't just write for, I'm going to give you 5 years worth of a drug, right? Because it's usually not super clinically responsible because, again, you oftentimes want to follow up with those patients and see them again to make sure that they're, you don't need to change anything. Okay. The receptor that becomes phosphorylated then dimerizes to initiate a cellular reaction is... I think one person's missing. Oh well. Tyrosine kinase receptors, right? So how did G protein coupled receptors work? Yeah, so remember you have the alpha, beta, and gamma subunits that are attached together. Remember they have that DP that's located on there. Once those get phosphorylated after the receptor gets bound, then it dissociates and they can go and activate things like adenylyl cyclase or cyclic GMP or whatever it needs to do, right? Ion-gated channels, typically they just have either an open or closed state depending on when the receptor gets bound by whatever ligand is activating it, right? And then for the intracellular receptors, those are typically just, as soon as they get activated, that's when they can usually cause things like, gene transcription changes, protein production changes, things like that. But yeah, so tyrosine kinase are the big ones. So think like insulin receptors act this way. A lot of newer cancer drugs are going to be working specifically on inhibiting these tyrosine kinase receptors. So these are very, very important for cell signaling. Okay. All right, which of the following methods of dosing may be most affected by extremes of weight in children? So why is this the correct answer? It never takes into account weight, right? You're only taking into account the age of the patient and not actually what their weight is, okay? For weight-based dosing, certainly weight is the only thing you're looking at, but that can have some problems with extremes of obesity in some cases. And then probably body surface area is the least likely to be influenced by this because we're looking at what other feature? Just remember? Their height, right? So you're factoring in their height and their weight into the body surface area calculation, so that helps to lead to those changes in weight to have less of an effect on that, right? So it's very easy if you're just age-based dosing to under or overdose kids very easily by even moderate shifts in weight, okay? So good to remember those shortcomings for the different dosing methods. A 40-kilogram patient is given 100 milligrams of a drug with a resulting concentration of 16 milligrams per liter. What is the volume of distribution? Again, this is harder math than what's on the test. Okay. All right, nice job. 36 of you. Okay, so let's work why that works, or why that's the correct answer. Okay. So again, what are we working with? What's our equation?
So do VD is dose over concentration.
Okay, yeah, so we can go back to VD equals our dose over that C0, right? So we just kind of flip-flop the VD and the C0 in that equation. So VD equals dose over C0, okay? So that means our VD is going to equal 100 milligrams divided by 16 milligrams per liter, right? So again, we go with. Okay, so what do you get when you divide this out? Yeah, 6.25, and what's my units here? Liters at this point, right? So that's just liters. So for a 40 kilogram patient, his volume distribution is 6.25 liters. So if I want to backtrack that to the liters per kilogram, I would do what? Divide by 40 kilograms. Oops. And they equal 156 liters per kilogram. Make sense? Okay. Is this a low or a high volume distribution? It's low, right? So that means the drug is preferentially staying where? In the plasma, right? Which is why when you measure that plasma concentration, it's like 16 milligrams. So that's a fairly high, fairly decent plasma concentration you're getting there. So again, because it's a low volume distribution, it's all staying in the plasma. Okay. Which of the following differentiates a toxicant from a toxin? Right. Yep, so what's an example of a toxicant?
Lead.
Yep, lead's a good one, right? It's a non-biologic, it's just a metal. What else? Lead's kind of a heavy topic, though, right? Any other examples? So why is the green answer incorrect? Yeah, they would be what instead? Toxicants, right? So anything non-biologic. So think about like most of your drugs are going to be considered toxicants in this case. Again, clinically, it doesn't come up that often, but it's important sometimes to know at least some of those distinctions. What would be an example of a pharmaceutical that is a toxin? Well, like a drug that we would give people therapeutically, but is also considered a toxin. Insulin, I guess, could technically be considered a toxin, I guess. Botox, yeah, this is what I was thinking of, Botox, because again, it's a natural product made by the botulinum bacteria, and then it can form that. Anyway. Right. Okay, drug A, we're given 100 milligrams daily to lower blood pressure by 15%, and drug B, we're giving 10 milligrams daily to do the same thing. What would be true here? The correct answer is these drugs are equipotent. Why is that true?
They have the same effect.
Yeah, they're getting the same exact effect. They're both lowering blood pressure by 15%. Works out that they're equipotent in this case. So drug A is more potent. Is that true? Not true? Yeah, we can't say that for sure, right? So we can't say based on what we're seeing here that it would be more potent necessarily. I'm sorry, drug A would not be more potent. So again, looking at the dose that we're giving, like notice how the dose of drug A is higher, right? So it would be less potent in that case, right? So you need more drug in order to get the same effect, right? Drug B is less effective. you can't say that based off the information that we have, right? So you may see that if you were to increase the doses, that you may see that drug B tops out before drug A does, but at least at these doses they're going to be equipotent. And then drug A is more effective. Again, we can't really say that based on what information we have here. Okay. Which of the following is true about intravenous route of administration? Right. Why is that true? Well, it's going right into the vein, right? So you don't have to worry about it not being well absorbed, because again, it's all going straight into the system. So it would have the highest bioavailability. Again, eventually it'll get metabolized by the liver, but it really doesn't have that first pass effect like you would see with something like oral administration, right? What's extravasation?
And the drugs in the tissues.
Yeah, so basically, you're trying to give something into a vein, and the drug either below the vein or whatever happens, or it's able to partition that drug out into the tissues, which can be potentially very dangerous. Sometimes it doesn't matter, but sometimes it can be very, very dangerous, causing tissue necrosis and whatnot. So that would not be the case. Slow onset of action. It should have very, very fast onset of action, especially compared to oral or transdermal. It should have fast onset of action. And then medications can be easily removed when you give it that way. Once it's in the system, that's it. Which is why we always, if you're not sure, err on the side of going low and trying to give more versus starting with too much, which you may not be able to do anything about. Okay. In phase 1 trials for a new drug, who are the test subjects? Good thing I already gave this one away. I did not write this very well. These are very poorly worded answers. I will forgive anyone for getting this one wrong. Dude, you won't get it wrong. You guys already know what it is. Perhaps I was in a fugue state when I wrote this question. Not to my usual snuff. Okay, so that was my goofy. So these don't actually make sense, right? Healthy patients with the disease state, these are kind of contradictory to one another. So I guess this would be the same. Unhealthy with it. I apparently was not thinking very clearly when I wrote this question, so I would throw this one out for next time. But also not laboratory animals. When would lab animals be tested upon? Yeah, the preclinical trials, right? So these are the clinical trials, but it would be preclinical. You do that. So again, healthy patients without the disease state, that's going to be phase 1, right? So you may think some of your patients are animals, but that's not the case for these clinical trials. Okay, how long does a drug company have on a patent to make their money back before it expires? After they file their new drug application. It's good because if you know this, you can look up to see when the drug was originally filed for a patent, and then you can figure out when it's going to go generic, right? So it can be very useful for patients who need a cheaper alternative to their drug. $20, right? So again, do they sell the drug as a brand name drug for 20 years? No, right. So when they go to the FDA and say, hey, we would like to do clinical trials for this drug, they file for a new drug application or an NDA, and then that starts the clock, right? So if it takes them 18 years to get through the clinical trials to get on the market, they only got 2 years to make that money back, right? So obviously it behooves them to get through as fast as possible, and so that way they can recoup their money as quickly as they can. Because again, for every drug that comes out in the market, there are thousands and thousands that have never see the light of day because of poor safety and things. They still cost money. Okay. How cool is pharmacy? Only 10 seconds on this one. See if you guys can get this right. Oh, right. A lot of you guys got the answer correct. I'm glad. The two of you, we'll talk about pharmacy school later if you like. Just kidding. Actually, I was expecting like none of the first two answers and all of the last two. But you guys restored my faith in you guys a little bit more. Good job. Okay. Again, that was no points. No points for that one. That would be unfair. Okay. Yeah, so you see, sucking up to me didn't really help you in that case. All right. So why do graded dose response curves exhibit a plateau effect at the upper end of the doses studied? Right, so remember on those graded dose response curves, that's where you're seeing basically that plateau happens when all the receptors end up being bound, and increasing the dose any further just means that you have extra drug floating around. It doesn't mean they're going to be interacting with any more receptors. They're all bound up. Now, on the other hand, if you're looking at one of those quantal dose response curves, where it's kind of like a yes/no, did the patients experience the effect you're looking for? Why would that plateau effect happen there? So it could be related. Usually it's either that the patients, 100% of patients are now experiencing the effect, right? So if it was like sleep with inhaled anesthetics, at a certain point, 100% of people would fall asleep, and so that would be considered your 100% mark. And so increasing the dose any further doesn't mean any more people are going to respond to it. The other thing could be it could be another situation where the receptors all get bound. If you're dealing with a drug that only has, say, limited efficacy. So if it's something like pain control or blood pressure reduction or something like that, you may see the same kind of issue happening there. But it's a little bit different when dealing with that quantal response curve. Okay. Last question. Which of the following occurs after chronic administration of a competitive antagonist at a receptor? Working with limited space count here. So. Okay, so what is another name for this process here? Upregulation, right? So if you're chronically blocking the effects of an endogenous ligand and a receptor, you're going to have upregulation in order for the cell to start to get that signaling happening again, right? So it's a homeostatic kind of compensatory process there. Good. Okay, so any questions on that? Right? So if we had chronic administration of an agonist, what would you see? Downregulation of receptors, right? So the cell would start to either internalize those receptors, or as they get degraded, it would not put out new ones, essentially. Okay, fantastic. All right, the winner, cytochrome P450. Who is it? Nice job. My advisee. I will not to brag. How about Drudger Bat? Okay. Very nice. Oh, another one of my advisees. Fantastic. I did not give them answers beforehand. I'll say. And then Meme Lord 5000. Really? Good. Good job. Third place. The free answer for the test is C. All right. Any other questions I can answer before we adjourn? If not, all right. I will see you guys next time.